Thank you so much. It's such a pleasure to be here. Let me just pull up my slides here. All right. So I have no financial disclosures. I am hoping that today we can define the difference between palliative care and hospice, gain an awareness about the data supporting palliative care integration into oncology, define this core concept in palliative care called prognostic awareness, and think about it specifically in the setting of mental illness. So this is a critically important topic, and it is really important that everybody in the room is we all have to do this together. This is not just the oncologist or the palliative care person or the social worker doing it. It is all of us, everyone who cares for these patients in any setting. And to talk a little bit about how we help patients, as Kelly was talking about, Susan Sontag talking about living in two worlds, holding this dual framework of living well while they also have this deeper awareness that dying is a possibility. So what we know from the literature is that all patients are really clear that if they're living with serious illness, they want more things than just living longer. It's not just about life prolongation at all costs. And I think one thing that's tricky in the mental illness context is there are times when that patient who doesn't want to get out of bed, you wonder if they didn't have schizophrenia, could we engage them in some other way, which I think is an important question. It's also an important question, even in this golden age of oncology treatment, there are many patients we can't cure. Right? Both things are true, and we have to have a deep understanding. If living longer isn't possible, or even if it is, what other goals are important? And the literature suggests patients want exactly what this patient who was described just now wanted. They want relief from pain and other symptoms. They don't want to be a burden on their family or their loved ones. They want to have as much control as possible, often in an illness that robs them of control. They want to strengthen relationships with loved ones. And they want informed, shared medical decision-making with the care team. And most patients will say to me, hey, Vicki, if I'm living, help me live. But if you actually think I'm dying, don't make that dying part longer, right? But then the question is, how do we know if we're living or we're starting the dying phase, right? And that requires a really open, clear dialogue with the team. So I'm going to start with just a couple definitions about what is hospice and what is palliative care, because it's super confusing for people, and so we can just put it to rest. So hospice is actually a medical insurance benefit that and it's meant for people in the last 6 months of life. So two doctors have to say, yes, we think if the illness takes its likely course, the patient would live less than 6 months. In most situations, it is difficult for patients to get chemotherapy or disease-modifying therapy like radiation while they're on hospice. It's not impossible, but it's quite difficult. Hospice can be provided at home, including a group home, in a hospice residence or facility, depending upon what's happening and the insurance that the patient has. I think it's important to know it is the gold standard of end-of-life care, of very end-of-life care. So if someone's suggesting hospice to your patient, don't think that that means they're giving up on them. It may mean that they actually think that is the best way to get them care in that last few months of life. Now, what's palliative care? Palliative care is a medical subspecialty for people with serious illness and their families. It's a very holistic approach. My job, when I walk into a patient's room, I say my job is to help you live as well as you can for as long as you can. So I work on improving quality of life as defined by the patient. It's appropriate for any age, any diagnosis, any stage of treatment, and happens at the same time patients are getting disease-modifying therapy. So I see patients who are getting bone marrow transplants. I see patients who we think will be cured from their cancer but have terrible symptoms. I had a patient I saw on Tuesday. He's got a tumor in his pelvis and he can never sit down. That's not great quality of life, right? So even though he's likely to live 20 years with this cancer, I see him to try to help improve his quality of life. Palliative care is an interdisciplinary team, and we think about ourselves like an extra layer of support. So we're with the oncology team together in the deep end of the pool, trying to help this patient and family do as well as possible. So I would say for all of you who are trying to think about the messaging, it's really important that you're clear about the messaging about what palliative care is and what it is not. So yes, it's for seriously ill patients. It doesn't mean that they have to be dying, okay? It's about matching goals and values about what's important. Like this patient wanted to get to the coffee shop. Awesome goal. I should be helping the team help him be able to actualize that goal. It's not about giving up. It's an extra layer of support to the team. It's not about rationing care. And I see myself as my job is to empower patients to have their voices heard. And I would imagine that every one of you in this room feels like that's part of your job too. So know that palliative care can partner with you. It is not the thing that we start and we call up when we're like, oh, there's nothing else to do. If we wait until then, we have missed our opportunity to really partner to improve quality of life. I would also say that question that was asked of this patient, what matters most to you, is brilliant. And that's what we do in palliative care, and each of you should become facile with doing. This is not about death panels or refusing people the care that they want or need. It is about making sure that they're getting what's important to them. So Dave mentioned this study that we did at MGH, which was a study for patients with advanced lung cancer, with metastatic lung cancer. We saw patients at the time of diagnosis and then monthly until the end of their life. And there were multiple outcomes of that study that were interesting. One was that patients had improved quality of life, which, whew, thank goodness, that's my job. Would have been super embarrassing if that weren't true. But so they felt better. The thing I'm probably most proud of is they had a 50% lower rate of depression. So if anyone tells you that talking about these things makes people depressed and give up, not supported by the literature. Stop that myth right now. Now, in this study, and the reason it got a ton of press, was we showed that patients who had early intervention palliative care actually lived about 3 months longer. We didn't look at survival as an outcome because we thought we prolonged life. We wanted just to make sure that the survival was the same in each group, because we knew people would criticize us and say, sure, Vicki, you made them feel better, but they died 6 months earlier. But that is not what has happened. So what do we do? What's in the palliative care syringe? We spend more time assessing the patient's understanding of prognosis and treatment, and we're one of 20 conversations or 40 conversations that happen with these patients. We might be 10 of those conversations to help them really understand and make sense of what's happening. So I would say a central goal of early integrated palliative care is to cultivate prognostic awareness. And I'll define that. I would say this is important for patients and families, and it's also really important for all of their clinical team who cares for them. And I would say uniquely, if a patient's been living in a group home for 20 years, that family, just like we heard in this story, have to come to terms with that too and be able to figure out how to have conversations with the patient. So the concept of prognostic awareness is this dynamic understanding of one's life expectancy or illness trajectory. And why is this important? Because patients, when they have a deeper awareness, can weigh the burdens and benefits of treatment, they can have more meaningful discussions about their goals and values, and they can match their treatment decisions to their goals and values. And empowering patients to live well is actually part of what we all need to be doing. This whole idea of helping a patient make a decision about resuscitation preferences, patients make really different decisions if they think they're going to live 10 years or if they're going to live 10 months, right? That just makes sense. If we think we can cure something, a patient may be likely to go through very, very difficult treatment for the chance of cure. They're less likely to want to go through really aggressive treatment if it means that they could live a month longer, 2 months longer. So we have to figure out, how do we as a team have these conversations? I'd say one thing that has just become really clear to me is in the setting of patients who are not living with serious mental illness, and I would imagine it's even more true with patients who are, is that this integration happens over time. This is not something anybody makes sense of immediately. And it's impossible to live with an awareness of your terminality every moment of every day. And so there are times when patients will be able to talk about it and times when they can't. And that doesn't mean that they're not doing it the right way. That's just normal, because this is overwhelming. And I think what's hard about that is sometimes I'm in the room with the patient, I'm like, are we on a day where we're going there or are we not going there today, right? Like, I have to figure that out. And I would imagine it is even more, and I have seen this, even more powerfully true in the setting of patients with chronic mental illness. On Tuesday, I saw a woman who had a sort of long-standing psychotic disorder, NOS kind of thing. And what was really fascinating is when she could go and have these deeper conversations during our hour time together and when she couldn't. And I just had to be nimble. It was like a dance. And making sure that everybody else on that care team knew what she was capable of, where she was in that moment. I think the other powerful piece is that this integration and prognostic awareness, we as a team have to have an understanding. So the idea that the group home folks really struggled makes sense too. They need to cultivate prognostic awareness and how the patient is making sense of their illness as well. So we think about this sort of prognostic awareness as a pendulum, that patients will start out thinking, I'm doing fine. I'm healthy, I run, I'm okay, I'm probably gonna do okay with this illness. And over time, as we heard with this patient, their body starts to give them cues that things are different, right? And that he felt more fatigued and had a sense that maybe this was not going to, maybe he was sicker, and he was able to then integrate and have a different conversation. So I want to introduce you to a patient of mine who I cared for. Her name is Betsy. She's not a woman who is living with severe mental illness, but the reason that I want to show you a couple video clips is I want you to see how hard this is for somebody who has good health literacy, does not live with chronic mental illness, and also has a great support system. So let's take these concepts and think about how do we translate them into patients who have severe mental illness. So patients are ambivalent about having these conversations. Let's hear what Betsy says.
You'd been unclear about whether you really wanted prognostic information, right? Because can you talk a little bit about that, about your desires for prognostic information and how you've thought about that?
I would love to talk about that because I think it's actually really, really important for doctors to know that as a patient, as a patient with a brain, I think I should know all about my health and all about my health care and all about prognoses and outcomes and all of that. I think that's the right thing to do. And then I ask a question and I realize I don't want to know the answer, but I've already asked the question and the information's out there, and then I'm devastated. Right. So I think that when doctors when they hear a patient ask a question, I hope that doctors think very carefully about why is this person asking this question and how much information, and can I give this information even though it's horrible information in a hopeful way.
Right. So I think when we think about the patient we heard earlier, this is about both things. It's about this is where we are and let's get you to the coffee shop. Like, that's a really hopeful, important thing. Hope doesn't need to be only cure or living longer, right? So we all need to think about this shift. And the reason we want patients to have this deeper prognostic awareness is it does change the medical decisions they make. I think when we think about this as our job, everybody in this room, it's not saying that the patient's going to say, great, I'm going to have a kumbaya death and I'm cool with that. That's not what we're saying. We're saying that we're able to have the patient hold both realities, that dying is possible. And if that is possible, what does matter most to you? What's important to you in that context? And patients often, over time, can begin to hold these two concepts more closely, more intimately, and it informs their medical decision-making. So I would encourage each of you to think when you're working with patients with a serious illness and a serious mental illness, to think about this framework that we use in palliative care, which is assessing their prognostic awareness, trying to help them hold both of these concepts, helping them focus on living and whatever living looks like for them, while they also acknowledge dying. And this assessing prognostic awareness, we may ask, what's your understanding of your illness? We would maybe say, what are your hopes in light of your illness? I find that some of my patients who I care for who have severe mental illness, that question can be too abstract sometimes for them. So this question that was asked, like, what matters most to you, is really helpful. Or what do you need right now? Or that we actually, as clinicians who are in your group home with these patients, you know what matters most. You see it every single day. And that's how you advocate for these patients. And is there a way for them to talk about their worries? So helping them hold both of these concepts, this dual framework, where they're able to have a space for talking about their worries. Talking about their worries does not mean you're making them hopeless. That's an important thing to remember. So how do we align with hopes, and how do we help cultivate this dual framework? Sometimes I will use ways to say, I'm glad you're feeling really well, and let's think about how we can get you to do these things that are important to you. I also work to empathize with the experience. It's hard to have an illness we can't cure. Sometimes patients need to hear that piece of information many, many, many times, and it doesn't matter if they have mental illness or not. Coming to terms with one's mortality is very, very difficult. I'd say another piece that's super important is figuring out what does living mean for the patient, and focus on what that is and how can we help achieve those goals. As we said in this case, that is what is hopeful. I'm going to sort of move through these slides quickly just because I want to make sure that we have time for the continued discussion. So we think about focusing on living in multiple ways. One is making sure that symptoms are in good control and that we're helping patients cope well, manage their worries, and do the things that are important to them. I think Tara is going to speak a bit about the role of social work in this space, Tara and Amy. And I think thinking about all of these coping strategies that you think about all the time, we should be especially employing in patients when they're really struggling in this space. Another piece that I think is really critically important is remembering that we can be hopeful with them too. So sometimes patients will say to me, I can't believe that I could die from this. I'm really hoping they're wrong. I think it's really okay to say, boy, I hope they're wrong too. Right? I'd love to see that happen. And how do we live with you today? Like, what do we do right now? And I think all of us who are living with these patients need to feel comfortable going there with the hopes and with our worries and acknowledgement that the dying piece actually could be possible. And so this acknowledging dying helps people integrate. It helps them actually discuss the possibility in a way that helps make it safer. And I would say the people who know these patients best, whether they're family or you're in the group home, if we can't tolerate having these discussions, we are telling patients really clearly that this is so scary that nobody can talk about it. And that is a serious problem. So part of what I would say is to be the advocates that you are in every single area of this patient's life. This means getting skill in this space too, so you can clearly advocate for them. I'm going to just show this quick last video as I finish up, and to say that this concrete thinking that happens for all patients. And so don't be surprised if you see this in your patient population, because we see this in patients who are not living with serious illness.
One thing that I remember was many times in outpatient clinic, you'd ask a question and I would say, is this information you want to know? Because there aren't any right or wrong answers. And most of the time you said, I don't want to know.
Right.
And when you were in the hospital and Tim was coming to visit, you said, I think I need to know, because you wanted to be able to give him some sort of grounding in it. And I think, do you have a sense of what changed for you in that, or how, because I think you're right, most patients have exactly what you're describing, which is they know they're supposed to be the good doobie patient who knows all this stuff and is an informed consumer. And then in their heart of hearts, they're like, listen, I don't really want to know this because I don't know that's going to help me. Right. But it seemed like there was a shift for you, and it seemed to my experience of it was that it was around talking to your children.
It is around talking. I have felt that the kids, especially my son, was overly hopeful. That he thought I was going to be cured. Right. And I needed him to know that this was not going to happen. I needed him to have a little bit of reality dose. Right. And I think he got it. But it was hard because, he wants the best, obviously. And so I asked so I could deal with him. Right. But now I'm back to I don't want to know.
Right. Interesting. Yeah. And what I hear in that is that you are holding the fact that this can't be cured and living very fully as you can day to day, but don't feel like having many more any more clear prognostic information would be helpful to you.
No, it isn't
Yeah.
helpful. I mean,
Yeah.
we're where we are.
Yeah.
I had a CAT scan not too long ago, and I told the care team, I don't want to know the answers. I don't want to know the results. They aren't going to do me any good at this point, so let's just keep that from me. And that's fine.
So I think the thing to know about this is even patients who have not been living with serious illness or mental illness, have not been living with the trauma inflicted on them by the medical system, still are ambivalent in this way. So don't be surprised when your patients who have had those experiences feel that way. And our job is to work with them, to help them begin to have a language around this so we can help them figure out what matters most to them and empower them to do that. So thank you, and I'm so incredibly grateful for the work that each of you does to help patients living with cancer and with serious illness, and with serious mental illness. Thank you.